There's also something called a moderator band that we find inside the right ventricle only. The moderator band is a specialized trabeculae carinae, only in the right ventricle, runs from the interventricular septum. The interventricular septum is the wall between the two ventricles, and it goes from the interventricular septum to the right ventricular wall, and it's part of the conducting system. So you may see a moderator band when you're in the laboratory. We're going to see that in the right side of the heart, in the right ventricle, that is again deoxygenated blood. That deoxygenated blood from the right ventricle is ejected into the pulmonary trunk and through the pulmonary circuit, while blood from the left ventricle, which is going to be oxygenated, is ejected into the ascending aorta. So again, here's your right ventricle, here's your left ventricle. Coming across the front, this is always the way I kind of tell which side am I looking at, the front side of the heart or the back side of the heart, as I look for the two auricles, and those two auricles are almost hugging the pulmonary trunk, which comes across the front of the heart. And so there's the pulmonary trunk coming up here, so this is the discharging vessel for the right ventricle. And then in the center of the base, you're going to see the ascending aorta coming out the center of that, and that's discharging for the left ventricle. And so here is the auricle from the left, auricle from the right. Here's your pulmonary trunk, and the aorta is in the center. So we need to talk a little bit more about fetal circulation. We kind of talked a little bit about it and how we have where oxygen basically is coming from. But if we think about it, the placenta develops from the in the uterus alongside the fetus. And so here's the developing placenta and the developing fetus. And we see that maternal and fetal blood are going to communicate within the placenta. They get close enough to be able to do exchange at that point. So then we're going to see that the placenta allows for the delivery of nutrients and removal of waste products from the fetus. And this communication occurs through umbilical vessels. So when we look at the umbilical cord, its connection between the mother and the fetus at the placenta. And when we look at that umbilical cord, the umbilical cord has one umbilical vein and two umbilical arteries. So one umbilical vein, two umbilical arteries. The umbilical vein, which seems a little backwards, but the umbilical vein is actually what's going to end up having nutrient-rich blood and oxygen-rich blood coming back to the heart. Remember, the definition of a vein or an artery is not, does it carry oxygenated blood or does it carry deoxygenated blood? But the definition of a vein is a blood vessel that approaches the heart. Definition of an artery is that which blood vessel that's coming away from the heart. So the umbilical vein, what we're going to see is actually going to bring nutrient-rich oxygen and nutrient-rich blood and oxygen towards the fetal heart, while the umbilical arteries are going to carry the deoxygenated blood out of the fetus towards the placenta. What happens after birth is these blood vessels are going to close. So here is the front of the umbilical, the abdominal cavity. This is where the belly button is going to form here. So these vessels are still within the body here. And so these will close down after birth and create ligaments. And if you were looking for the umbilical vein in the adult forms the ligamentum teres hepatis. It's going to be a ligament associated with the liver. We've talked about that one before. And then we're going to see that in the adult for the umbilical arteries, these will close down and form ligaments lateral to the bladder. So the bladder would sit right here in between these two that then close down. So here is the umbilical cord here. We have our one vein and our two arteries. Our vein is bringing in blood. Here's the umbilical vein. The umbilical vein wants to get that oxygenated blood to the heart so it can discharge it around the body. Well, the first thing it runs into is going to be the liver. And so it's going to have to be shunted across the liver to get to the inferior vena cava and then follow that to the heart. So we're going to see that the umbilical vein, which we see here, is then going to be shunted across the liver directly into the inferior vena cava through what's called the ductus venosus. And this is the ductus venosus here. So that oxygenated blood will go from the umbilical vein through the ductus venosus over to the inferior vena cava. This will end up closing after birth because you don't need it anymore, and it becomes another ligament, and this is the ligamentum venosum in the adult.
I have a question. Going back to a ligament connects bone to bone, or?
So ligaments can also connect other structures as well. So typically when we think of most ligaments in the body, we think of them as connecting bone to bone. These ligaments are just folds of connective tissue. Okay. So they may be connecting other structures as well. So we'll see a lot of them associated with the abdominal cavity, where we see folds of the peritoneum. We also see them when blood vessels close and also then can create a fold as well. Yeah. Okay, so oxygenated blood is going to come in the umbilical vein. It's going to then be inside the abdominal cavity, and it needs to get to the inferior vena cava. It's going to take the ductus venosus over to the inferior vena cava. From the inferior vena cava, it's going to come up and can get into the right atrium. From the right atrium, this is now oxygenated blood, but it's on the wrong side of the heart. The lungs are non-functional, so most of the blood is going to be shunted from the right atrium to the left atrium through the foramen ovale. So it's going to be able to come across here. Some of the blood, though, does make it from the right atrium into the right ventricle, but we still want to shunt it to the other side. So there's a second bypass. If you come up the pulmonary trunk, at the end of the pulmonary trunk, where it divides into the pulmonary arteries, there's this little other shunt right here, and this is called the ductus arteriosus. The ductus arteriosus shunts any blood that made it into the pulmonary artery over from the left pulmonary artery over to the aorta. And so it's another mechanism to bypass the pulmonary circuit. This ends up closing, and so you end up with this little ligament after birth that is going to connect then the pulmonary trunk or the left pulmonary artery to the aorta. So if you take a probe and try to slide it up the ascending aorta, you end up hitting this ligament. At this point, you can only go so far when you're going to hit this ligament, which is the remnant of the ductus arteriosus. Yeah.
So these ligaments don't close when, these ducts don't close when the lungs become functional?
Basically, that's what happens. So as soon as the baby's born, what's going to happen is there's smooth muscle in the wall, and that smooth muscle will get the signal to contract, and it closes it down.
So the lungs don't become functional until the baby is born?
Correct. Yeah. So they are basically the last organ system to develop because they don't need them at that point because you're getting oxygen from mom. So last organ system to develop. Okay, so this shows you that flow of blood. Again, here is where the belly button is. There's the umbilicus right here. Here is the umbilical cord here. And so we know blood, oxygenated blood is going to come in through the umbilical vein. It's going to be shunted through the liver, through the ductus venosus, into the inferior vena cava. That blood then comes into the right atrium, and most of it's going to shunt across through the foramen ovale. But some of it does make it down and up out the pulmonary trunk, and here's the ductus arteriosus. The rest of it can then, or the majority of it can also then come through here as well. It's going to circulate through the systemic circuit, and then what we're going to be able to do then is bring that blood, now deoxygenated through the umbilical arteries, there's two of them, back out through the umbilical cord into the placenta to allow for exchange to take place. So during embryonic development, both the foramen ovale and the ductus arteriosus are going to shunt blood away from the pulmonary circuit. Right side of the heart is non-functional. We leave a little bit of blood over there to get it developing, but we're going to see that what we really want to use is that left side to get the blood out into the systemic circuit. You need to think about what are the structures we see in the fetus, and then what are the structures we see associated with the adult heart. So for example, they're showing you here the foramen ovale. That is a structure we see associated with the embryonic heart. The adult structure, what's the remnant of that, is the fossa ovalis, that little thumbprint-sized fossa that we see in the interatrial wall within the right atrium. The ductus arteriosus, which we see here, becomes this little piece right here, which is the ligamentum arteriosum. The ductus venosus, which bypassed the liver for us, becomes the ligamentum venosum. Umbilical vein becomes the ligamentum teres hepatis. It left the hepatis off of that, and the umbilical arteries become the medial umbilical ligaments. So think about what you see in the embryonic heart. Think about what you see in the adult body. That's the remnant of those particular structures. So here we see the fetal circulation again on this side. And then what we see after birth, which is what we also see in the adult. So those changes take place very quickly. A lot of these structures you may have heard of before, things like the ductus arteriosus. You watch House, that TV show, a lot of times they'll talk about a lot of these bypasses not closing down, and that may be one of the reasons why they're having any particular disease, problems with the heart or any other issues. So please, you can listen for those words. Any questions? Okay, so let's think about now the valves of the heart. And valves of the heart are going to open and close in response to pressure changes. So it's pressure changes that open and close them. There are 4 valves associated with the heart. There's 2 atrioventricular valves. They are going to be between the atria and the ventricles, and they prevent the backflow of blood from the ventricles into the atria. There is what's called the tricuspid valve. Another name for the tricuspid valve is the right atrioventricular valve. You should know both names. So tricuspid valve or right atrioventricular valve. And it's given that name because it's on the right side, between the atria and the ventricles on the right side, and it's called tricuspid because there's 3 cusps associated with that particular valve, so 3 flaps associated with it. On the left side is the bicuspid or the mitral valve, and that's the left atrioventricular valve. It has 2 cusps associated with it, and it's also called the mitral valve. That goes back to Latin, and if you've ever seen, for example, the Pope, and he wears that big hat that has a flap in the front and a flap in the back, it's called the mitres hat. It has 2 flaps associated with it. That's where, again, that terminology is coming from. Again, it has 2 flaps associated with this particular valve on the left side of the heart. Remember, it's the atrioventricular valves that are also tied to the chordae tendineae and the papillary muscles. The papillary muscles, again, are not opening and closing these valves, it's pressure changes, but the chordae tendineae and the papillary muscles are holding on to these valves to make sure they don't prolapse, they don't pop back the other direction when the ventricles contract. There's also outflow tract valves as well, so between the ventricles and their respective outflow tracts. And so this prevents backflow of blood into the ventricles. There's the aortic semilunar valve. The aortic semilunar valve is on the left side, so that's between the left ventricle and the ascending aorta. There's also the pulmonary semilunar valve that's on the right side of the heart between the right ventricle and the pulmonary trunk. Both of these valves have 3 cusps or flaps associated with them. These semilunar valves do not have chordae tendineae and papillary muscles attached to them. They're not needed. There are no valves associated with the entrances of the vena cavae, the coronary sinuses, or the pulmonary veins into the heart. That's because the pressure is so low at that particular point. Pressure is incredibly low. So what they've done in this particular image is they've gone ahead and sectioned off the aorta, the atria. So the 2 atrias have been removed, we just have the ventricles left, and we're looking down on that cut surface. And when we do that, we remember that the aorta is coming out of the center, and so we know that this is going to be the beginning of the ascending aorta. pulmonary trunk comes across the front, and so this is gonna be the beginning of the pulmonary trunk, and these are the two atrioventricular valves. So if we look at those, what we're gonna see is that we first have on the left side, the bicuspid mitral or left atrioventricular valves, which have two cusps associated with them. And on the right side, we have the tricuspid valve, also known as the right atrioventricular valve, and it's gonna have 1, 2, 3 cusps associated with it. And what you can't see here is on the opposite side, the chordae tendineae are attached to these and then attached to papillary muscles to hold on to them. Here we have the aortic and the pulmonary semilunar valves, which have 1, 2, 3, 1, 2, 3 cusps associated with them. And so this image, we're bringing this one back so to remind you that attached to the atrioventricular valves are going to be the chordae tendineae. And then at the papillary muscles at the bottom there. So this is the papillary muscles attached to the apex of the papillary muscles, so the chordae tendineae, which attach to the atrioventricular valve flaps. When the ventricles contract, so do the papillary muscles, take up the slack of the chordae tendineae and hold on to the atrioventricular valves, make sure they don't prolapse. This image is also really nice because it also brings home the point about the thickness of the walls. And I think we've talked about this before, that if you think about the atria are going to only have to push blood from the atrias down to the ventricles. So basically from here down to here. That's not very far. And 70% of the blood that's going to go from the atria to the ventricles is going to do so passively. It just, gravity makes it fall down into the ventricles. And so the atria themselves only have to give a little tiny squeeze, so it's only a little bit of pressure they have to develop to push that last 30% of blood down into the ventricles. Then the ventricles are going to have to contract. So if you think about the thickness of the walls, the atria are going to have much thinner walls than the ventricles, because then the ventricles are going to have to push the blood out and around the different circuits, obviously a lot further. But look at the difference in the thickness of the walls of the ventricles. This is going to be left ventricle, this is going to be right ventricle. The question then is, why is there a difference in the thickness? Think about the distance each one of these are going to have to push the blood. If it's the right side of the heart, the right ventricle, it's only having to push the blood from the heart over to the lungs and back again. While the left side is going to have to push the blood up to your brain, down to your toes, out to your fingertips, and back again. That left side is going to have to overcome 5 times more friction or resistance to push that blood through that systemic circuit than does the right side through the pulmonary circuit. Therefore, when you see a cut section, you're like, oh, I can't figure out my orientation to where is, which ventricle is which is the right, which is the left. That left ventricle wall is much thicker than the right ventricle wall. This image just reminds you again that, the atrioventricular valves, not the semilunar valves, but the atrioventricular valves are going to have the chordae tendineae attached to them and then to the apex of the papillary muscles. They are not opening and closing the atrioventricular valves, they're just holding on to them to make sure they don't prolapse. It's pressure changes in the chambers that are going to open and close them. So you can kind of walk yourself through the heart cycle and think about what is happening during these different times. And you can pick any particular location to start this discussion. And if you think about, okay, everything's relaxed for, a fraction of a second. And then the atria are going to start receiving blood coming back from the different circuits. So that blood is going to come back and start to fill the atria. And the atria then allow for a little bit of blood, 70% of the blood to passively fall from the atria down into the ventricles. And then the atria give a little bit of squeeze. Get that last 30% of blood down into the ventricles. Well, obviously the atrioventricular valve flaps have to be open to allow for that blood to come through. So those are going to be open. Then we're going to see that the blood is now down in the ventricles and the ventricles begin to contract and pressure starts to rise. Well, that pressure change causes the atrioventricular valve flaps to close. The semilunar valves have been closed during this entire time. So now we have a closed chamber and it's contracting, and pressure is going up and up. This is also when those papillary muscles are taking up the slack of the chordate tenony and making sure those atrioventricular valve flaps don't prolapse. Well, pressure gets so great where then it's going to get to a point where it's higher than what it is in the outflow tracts, and it causes the semilunar valves to pop open. And liquid likes to go from an area of higher pressure to an area of lower pressure, and it's basically going to flow out the outflow tracts. So now it's going through the semilunar valves, and the ventricles are contracting and pushing that blood out. Well, then the ventricles are going to start to relax, and pressure is going to start to drop inside the ventricles. Well, pressure starts to drop to the point where now the pressure out in the outflow tracts is greater than it is in the ventricles, and blood's actually going to try to come back. But as blood tries to come back, it's going to get caught in the cusps and actually close off the semilunar valves. And now the ventricles are going to be completely closed again, but then the atrioventricular valve flaps are going to reopen. So you can see here how it's pressure changes that are causing those valves to open and close, but it's also those pressure changes that are allowing for the blood to flow from an area of higher pressure to an area of lower pressure. And as that's going on, there's also heart sounds associated with a heartbeat. And what we're going to see is that the first heart sound is going to be, and if you hear a heart sound, it's lub-dub, lub-dub, lub-dub. The lub part, that first sound, is actually the sound of the atrioventricular valves closing, and it signifies the beginning of ventricular systole, when the ventricles are starting to close or starting to increase pressure when they're contracting. The second heart sound, so the dub, that second heart sound, is actually the closing of the semilunar valves. And remember, the closing of the semilunar valves is when that blood is starting to come back towards the heart because the ventricles have started to relax. So it's actually signifying the beginning of ventricular diastole when the ventricles relax. So the question is, what's actually creating the heart sound? Now, the first heart sound is the closing of the semilunar, or the closing of the atrioventricular valves. The second heart sound is the closing of the semilunar valves. But it's not the actual closing per se that's making the sound, but it's actually the sound of blood turbulence hitting off of those closed valves. So if you go down to, say, the Olentangy, granted not lately, but for the most part, that you know that water is flowing, but you don't hear it. But if you go down to, say, the Gully River in West Virginia during gully season, when the rafting's real good down there, you can hear the water flowing because it's bouncing off of things, bouncing off of rocks. And that's the same idea here. What's happening is these valves are closing and the blood is hitting off of those closed valves. And it's creating blood turbulence, and that's what you're actually hearing. So as I mentioned, tracing is going to be really important for this particular unit. And so what you need to be able to do is trace blood through the heart and around the different circuits. So we can pick any location. So we can pick, for example, the right atrium. And so from the right atrium, we know that coming in is deoxygenated blood from the superior vena cava, the inferior vena cava, or the coronary sinus. From the right atrium, we go into the left, into the right ventricle, out the pulmonary trunk, into the pulmonary arteries, over to the lungs, through the pulmonary circuit. Now we are oxygenated, and we come back to the left side. Left atrium to left ventricle, out the ascend aorta, arch the aorta, and so forth. Drop off oxygen and nutrients, pick up waste products, and back to the heart. But as you do that tracing, don't forget about the valves. Make sure you add those valves in. So here are those three ways into the right atrium. From the right atrium, you go past the tricuspid valve. Also remember that you should know the alternate term as well. So you should say tricuspid or right atrioventricular valve to the right ventricle, past the pulmonary semilunar valve. So they left semilunar out there. Pulmonary semilunar valve into the pulmonary trunk, pulmonary arteries, over to the lungs. Pick up oxygen, drop off carbon dioxide, coming back through the pulmonary veins into the left atrium, past the bicuspid valve, which is also known as the mitral valve, or the left atrioventricular valve, past into the left ventricle, past the aortic semilunar valve, out the aorta into the systemic blood vessels, drop off oxygen, pick up carbon dioxide, and back again. So we could drop you off at any point along this pathway and ask you to put the structures in order, coming back and through the heart and then round again. Okay. Keep in mind, when it comes to the lungs, there's actually two sets of arteries. So when it comes to the lungs, there's actually two sets of arteries. We talked about the pulmonary arteries and veins. The pulmonary arteries and veins are rather large because they're the ones dealing with all of the blood that's coming out of the right side of the heart and then coming back to the left side of the heart. And they're part of the pulmonary circuit, but they're bringing deoxygenated blood over to the lungs. We still have to supply the lung tissue. And so there's another set of arteries and veins called bronchial arteries and veins that are much smaller. And those bronchial arteries and veins serve the lungs as part of the systemic circuit. So they're bringing oxygenated blood over to the lungs and picking up carbon dioxide and bringing it back to the heart. Okay? So when you're looking at the blood vessels associated with the lungs, if they're really big, they're going to be pulmonary. If they're much smaller, they're going to be bronchial. Yeah.
Is that applicable in like fetuses also? Since I know the lungs get bypassed for them, is that how they're oxygenated?
So they're still, yes, so they'll still, once the lungs actually develop. So the lungs don't actually develop till about, till the last organ system to develop, so much later. And so once they actually develop, they'll then develop the bronchial arteries and veins that go with it.